King Sean, do you have her phone or anything to send her a text? I don't know if you have it handy, if you have her cell phone handy.
Yeah, I probably wait another couple of minutes.
Oh yeah, no. We'll wait.
Looks like people are joining now, quite a few.
For those of you who are joining now, we're just chatting for a few minutes and waiting for folks to sign on. Our experience is it usually takes 5 minutes or so for the audience to assemble.
Yeah. Molly didn't get the link, so I just forward her the link.
I see Molly. I see her. She's on now. Looks like she's connecting. So welcome. I see folks joining in, and we're just waiting a few for the audience to come together. In the meantime, Tim, you have your slides up on your computer?
Yeah, we're all set.
Okay, great. And let's see. Oh, there, Molly. Welcome. Welcome. Do you have your slides up? Do you want to test the share screen?
You're on mute, I think.
There we go. Okay, great. Terrific. Molly, you're muted, just so you know. Mute, unmute.
There we go.
There we go. Okay, okay. And I'll ask everybody who's not speaking to mute, and we may have a large audience, so I think I will ask folks to put their questions as we go along in the chat, and then we can handle the questions that way. All right, we'll give it another minute for folks to collect, and then we will get going. Okay, well, let's get started. We've got a nice group. I'm Ned Nunes. I'm an addiction psychiatrist, professor of psychiatry at New York State Psychiatric Institute and Columbia Medical Center, and one of the co-directors of the Chosen Center at Columbia. Chosen is a center on the healing of opioids and other substance use disorders, and the purpose, it was formed recently, and the purpose of the center is to bring together investigators from all different disciplines that bear on opioid use and other substance use disorders and co-occurring disorders, psychiatric disorders, pain, to really bring people together across silos to think about data and to brainstorm about possible new research projects and directions. So today we have a very exciting program planned where we're going to look at a couple of different large community-based initiatives to try to help address the opioid epidemic, and specifically to implement interventions, medication treatments, and other interventions. So we are going to hear from two team members from the New York State Office of Mental Health. And we're going to hear from King-Hsien Chen, who is the director of the Bureau of Population Health within the Office of Population and Health and Evaluation at the New York State Office of Mental Health. And she's going to present to us some fascinating prevalence data about the surprisingly high prevalence of opioid use disorder in the mental health system in the state of New York. We're then going to hear from Molly Finnerty, who is the medical director and co-leader of the Office of Population Health and Evaluation at the New York State Office of Mental Health. And she also directs the Psyches system, which is a database that collects real-time data about patients coming into the mental health system. And she's going to talk about a major initiative in the mental health system to actually implement treatment for opiate use disorder within the mental health system, which is a very interesting initiative. And then finally, we're going to hear from Tim Hunt, who is a research scientist at the Columbia Social Work School and one of the key investigators on the New York Healing Communities Study, which is a NIDA-funded initiative to implement community-wide, community-based interventions in upstate New York communities to implement interventions for opioid use disorder throughout the community. And Tim is going to reflect particularly on the role of some mental health programs in those efforts in some of those counties. So I would like to now introduce King-Hsien Chen, who is going to share her screen and get us started. King-Hsien, you have the floor. Let's get your, oh, and one more announcement before we start. Put your questions into the chat, if you would, as we go along. And then we hope to have about 50 minutes of presentations and then plenty of time for questions and answers. So put your questions into the chat and we'll have a question and answer discussion. So King-Hsien, take it away.
Okay, thank you, Professor Norman. So let me share my screen.
There we go.
So,
Terrific.
Okay, thank you. So good afternoon, everyone. I'm King-Hsien Chen from the New York State Office of Mental Health, and I work in the Office of Population Health and Evaluation under the direction of Dr. Molly Finnerty and Dr. Lachman Weston. So today I'm going to present the epidemiology of opioid use disorder and overdose in the public mental health population in New York State. So the purpose of this presentation is to present the high prevalence of opioid use disorder among our mental health population. So we look at the demographic and the clinical characteristics associated with the opioid use disorder prevalence and also opioid overdose prevalence among our population. So we used the New York State Medicaid data for this analysis. So for this study, our population is New York State Medicaid mental health population. So mental health population is defined as having a mental health primary diagnosis in at least 2 outpatient claims or at least 1 inpatient claims in a clinical setting. So we also restricted the individuals with a continuous Medicaid eligibility in 2020. For this study, we look at the adults 18 and above. So our final population has about 524,000 individuals. Among those individuals, about a third of them had a co-occurring substance use disorder diagnosis in 2020. And the prevalence of opioid use disorder is about 8.1%. And among those, under 1% of those had an opioid overdose. Here are the list of correlates we examined for the opioid use disorder prevalence and overdose prevalence. So for demographics, we looked at age, gender, race, ethnicity, region, Medicaid, aid category, and the Medicare status. For diagnosis, we look at leading primary diagnosis assigned using the preponderance method. And we also look at the comorbid mental health and substance use disorders. We also look at the suicide attempt, suicide ideation, and housing instability, their association with opioid use disorder and overdose. And also we look at their service utilization patterns for those has overdose and have the opioid use disorder. Below, I will present some of our findings. So first, we look at the prevalence of opioid use disorder by demographics. And from this chart, you can see those adults aged 25 and older are significantly more likely to be diagnosed with OUD compared to those in 18 to 24. And the prevalence of OUD varies by race, where Asian and Black are associated with significantly lower OUD prevalence, while American Indian and Hispanic are associated with higher OUD prevalence. And the male, we also see male are more significantly higher than the female on the OUD prevalence. So for those with OUD, we look at their opioid overdose prevalence by demographic too. So 7.7% of mental health clients with OUD had an opioid overdose in 2020. Although the young adults are less likely to have OUD, but those with OUD, they are more likely to experience an overdose. And the prevalence of OUD has, although they have quite a large variation by race ethnicity, but the variation seems much less for the opioid overdose, for those among those with OUD.
Yeah, okay, take a look. Yeah, I can put those up. Okay.
Just a note, could everyone who please mute your microphones who are in the symposium? Thank you.
So we serve more than half of the mental health population in our specialty mental health outpatient services. So these slides look at the prevalence of OUD and opioid overdose by different specialty mental health outpatient service programs. So in particular, the prevalence of OUD are the highest in mental health clinic and the community residents and HCBS services. So however, among those with OUD, opioid overdose are highest in ACT, continued treatment, approach, and partial hospitalization. These are the settings of more severely mental ill individuals. So we see a 9.1% of those in our mental health clinic service had an OUD in 2020, and among those with OUD, 7.1% of those served in mental health clinic had an overdose. So this is the distribution of the primary psychiatry diagnosis in our population. So we use the preponderance method to assign a single primary diagnosis to each individual. So we look at their most recent 10 claims, and the diagnosis was assigned based on most common and the most recent or most severe diagnosis associated with the claim. So the most common diagnosis in our population are depression, and followed by anxiety, schizophrenia, bipolar, trauma disorder, and the PTSD. So we will look at the prevalence of opioid use disorder and overdose by these diagnoses. So here is the prevalence of OUD by the diagnosis. We use the depression as our reference group, and individuals with a primary diagnosis of anxiety, bipolar, and PTSD are associated with significantly great odds of OUD. And those diagnosed with a schizophrenia or trauma-related disorder are associated with significantly low odds of OUD. So for those with OUD, we also look at the opioid overdose by mental health diagnosis. And we also see less variation by the mental health diagnosis for opioid overdose prevalence. So in particular, those diagnosed with schizophrenia has greater odds of overdose if they are presented with an OUD. And those with anxiety and PTSD had a significant lower odds of overdose when they presented with OUD. So about 1/3 of individuals in mental health population had a comorbid of substance use disorder. Individuals with substance use disorder other than opioid use disorder are more likely to have an opioid use disorder. So in particular, those individuals with cocaine-related disorder are 10 times more likely to have a diagnosis of OUD than those without the diagnosis. And alcohol-related, cannabis, and tobacco-related disorder are also associated with significant higher OUD prevalence than those didn't have those diagnoses. So on this slide, we look at the prevalence of suicide attempt, suicide ideation, and housing instability among the mental health population with and without OUD. So the green bar represents the prevalence of those adverse events for those with OUD, and the blue bars are the prevalence for those with opioid overdose. We can see the rates are much higher for those with OUD and with opioid overdose. So we also look at the OUD prevalence by suicide and housing status. So nearly a quarter of individuals with a suicide attempt, suicide ideation, or housing instability had an OUD diagnosis in 2020. And a third of individuals with OUD and a suicide attempt had an opioid overdose in the past in calendar year 2020. So individuals with a suicide attempt, suicide ideation, or housing instability are 2 to 3 times more likely to be associated with OUD diagnosis and opioid overdose than those didn't have those events, didn't have those diagnoses. So in conclusion, we have an overall of 8.1% OUD prevalence among mental health population. And for the mental health population with OUD, 7.7% had an opioid overdose. And individuals with a primary schizophrenia diagnosis are associated with low odds of having OUD, but for those have OUD, they are associated with high odds of overdose. And individuals with OUD are associated with higher rates of suicide attempt, suicide ideation, and economic disadvantage, housing instabilities. So more than half of mental health population received a mental health clinic service in calendar year 2020, and the clients in mental health clinic service were associated with higher OUD prevalence. It's about 9.1%. And Dr. Molly Finnerty will talk more about our opioid initiative program among our mental health program, in particular the clinic program, in our next presentation.
Okay, Kingshan, thank you for that
Thank you.
wonderful, thank you for that wonderful presentation and fascinating data. And if you would stop sharing your screen, and next we're going to hear from Molly Finnerty, who is the medical director and co-lead of the Office of Population Health and Evaluation at the New York State Office of Mental Health. And Molly is going to talk with us about the opioid initiative within the mental health system, from which the data we just heard about derives. Molly, you have the floor. Thank you for joining.
Thank you. Can you see my screen?
Yes.
Great. Okay. Now, so I'm going to talk about one of the initiatives that OMH is
We
implementing.
can't see you, though. I don't know if you want to turn your camera on.
Oh, sure. I'm going to talk about one of the initiatives that the Office of Mental Health is implementing for identifying and treating opioid use disorder in our New York State public mental health system, and talk about our progress to date and some of our challenges. So in overview, I'm going to describe the mental health system a little bit, how this project came to be, a little bit about the implementation model that we're using, how we monitor impact, and our questions about challenges. So the mental health system is really the way we're set up here in New York State, is that we have multiple health agencies, as people are aware. And in some states, these are really just one, right? It would all be collapsed under a single, say, Department of Health that would address mental health conditions and addiction services as well. But in our state, that's 3 distinct agencies. And for OMH, we have over approximately 2,000 programs that are licensed or designated in different state, sites around the state. And the largest program is our clinic program, and that's if we exclude single bed kind of housing sites. But the clinic programs are really the largest single program type, and there's nearly 500 licensed programs, but each of those programs can have multiple satellites associated with them, unique sites and settings in their own distinct physical space. Those are our largest program type, and it's a map of how it's distributed around the state. What was the context for developing this program? So there was an increased concern and focus on the opioid epidemic at a national and state level. And in part, I'm a little embarrassed to say that in part because of these separate agencies that we have, at least I would think in our role, isn't that someone else's challenge? Like, we were aware of it, we were concerned about it, but we really thought, our colleagues have this well in hand. This is their expertise. These are the things that they work on, which is not to say, OMH was unaware or not taking steps within their own direct operated services, for example, but it didn't feel like our job, right? It didn't feel like our job. But it began to creep in, right? And in one way that struck me was, remember we were working on a grant, collaborating an effort with the center, a funded effort by Center of Medicare and Medicaid Services, for their practice transformation networks. And we're one of the, I think there's 29 funded networks, and we're the only one focusing on mental health, and we're focusing on all-cause readmission. And many years into the grant, they announced everyone has to add OUD as an outcome to their project. And it seemed a little bit out of left field, like, what are you talking about? We're all working on various things. We could be working on diabetes, or we could be working, but no, across the board, everyone had to add OUD outcomes to their project. And so, of course we did. But it was an example of how this pressure began to get felt within the Office of Mental Health, and their governor, as the epidemic began to swell, the governor's office called on all the health agencies to think about, investigate prevalence within their own settings to see what they could do to help. Another piece of context was our commissioner hosts a journal club, and one of my colleagues calls it the most dangerous meeting of the month, because in the journal club, you go in and you'll read an article, and ideas will come out of it, and initiatives are born. So it's a place where things can happen. And I was thinking, in a way, I would like to invite everyone here on the phone to consider this a dangerous presentation, in which you imagine what it is that we might do together, what it is that you might leave thinking you're going to have to do as work, or that maybe we'll work on together. So that was something. And we did an article on the opioid epidemic, and a question came up, I wonder how prevalent opioid use disorder is in our clinics. And so I worked with Chen and other analysts to begin to dig in to this question. And at that time, it was about 7% prevalence in our licensed clinics. But we did find out that only about half of them who were able to successfully identify their clients with OUD. So we could see the person had opioid use disorder. They were presenting in emergency rooms with overdoses, or maybe they were getting treated elsewhere for their opioid use disorder. But there was no mention of it in the clinic records. There was no record of it being submitted through Medicaid claims or encounter data. And that further, less than a third of these clinic clients with opioid use disorder being served in our clinic statewide had a filled naloxone prescription any time in the past year. And so this was cause for concern. And thus this initiative was born to increase capacity of OMH licensed clinics to identify and treat opioid use disorder. What was our implementation approach? So one thing I think is important to emphasize is that the approach is at a clinic program level intervention, and very particularly really at leadership or quality management, right? So it's kind of a intervention at the level of the clinic program. And that's the place that we're intervening. This was made mandatory for all of our OMH licensed clinics in the state, and that's the 482 clinics. In the planning phase, we identified 5 best practices for opioid use disorder in collaboration with academic partners. We also established and continued to grow a multi-agency planning team, and this includes our sister agencies at OASAS, Department of Health, the Office of Drug User Health, as well as the New York City DOH&MH, Columbia University Center for Practice Innovations, the Opioid Response Network, the Harris Project, and others. We also want to engage stakeholders. So especially when you're going out with a mandatory project, you really want to make sure, as best you can, that that people are aware, that they're supportive, that they stand with you in the importance of such an effort, right? So reaching out to provider associations, county, local government units that manage mental health programs in their counties, as well as our sister state health agencies and departments and offices that might be working on opioid use disorders. We also worked to identify resources and added these, sort of collate and add to the Columbia NYSB Center for Practice Innovations, made them readily accessible, as well as distributing in other ways. The project was launched in March of 2019, and there's sort of a structured change process that we follow. So first is really clarifying the expectation and the goal. So here it's that all the clinics would implement all of the 5 best practices over time. They would phase these in over time. At baseline and every 6 months, the clinics were expected to attend a project WebEx. They were expected to self-assess and submit their fidelity to the 5 OUD best practices. So we would distribute this and collect it again. And that each 6 months, they would select one of the best practices to add to their standard clinic practice or to improve their performance on. The support that was offered to them were these every 6 month kind of informational WebExes that were trying to gear themselves towards whatever issue seemed most pertinent at the time. So for example, the first round of WebExes after the COVID epidemic had hit New York State was how to do a induction of buprenorphine over the phone or by telehealth. Right? So it's sort of trying to make it our best sense of what clinics are struggling with now, what's most pertinent right now. In between these 6 month WebExes, there was office hours offered, as well as individual technical assistance, clinical consultation on request. Another critical component is ongoing monitoring and feedback to clinics on their participation and performance. There is an ongoing stratified communication strategy that includes reminders and outreach based on this participation and performance, and graduation criteria were established. This is probably a good time before I leave this to thank Annie Cummings, who is a remarkable individual who leads the implementation unit and you know, was nothing short of heroic in getting this work off the ground and making it run, as well as her whole team has supported these efforts in various ways. The 5 best practice focus on screening, providing naloxone prescriptions, and that would be by the clinic, that the clinic should be the one to do that as soon as opioid use disorder is identified. If the client prefers and or prefers it, you know, say methadone or a treatment that mental health clinics are not permitted to offer, that they would do a timely MAT referral with follow-up to ensure that it happened, schedule the appointment to make sure that the service is actually available. So a sort of a tight, well-followed MAT referral. That they would have waivered prescribers on staff and coverage, and that MAT would actually be delivered, and that they would do both inductions and maintenance for 2 types of MAT. So I think we're here. Okay, monitoring participation and impact. So there is a couple ways that this constant monitoring is critical to the way we do these initiatives. And again, kudos to Annie's team, who is remarkable in this way. So if there's an expectation set that you will attend the WebEx every 6 months, you'll get an invitation from the implementation team saying, hey, our next round of WebExes are coming up. Look forward to see you. Here's how you log in. And we offer multiple opportunities to attend. And then we see if you show up, you see if you register. And if you do not, you get some friendly outreach and increasing, and we don't let you go. And I should say that's Annie and her team. That's excellent at really holding people, and we don't let you go. So if we don't hear from you, there's more outreach. Often people change, you know, especially in these COVID times. The turnover in staff is tremendous, is high in general, but particularly high now with a lot of people being repurposed to different new roles in the face of the COVID epidemic. Lots of transition in leadership, lots of transition in institutions in general, leaving institutions. So finding the new leaders, reaching out, engaging the new leaders, doing makeup WebExes for them. The same with submitting the data. The data is required every 6 months. There's you're doing the whole state, right? So there's a blanket communication that goes out. And if you're lucky, most people do it. And then there's 1 reminder, 2 reminders, 3 reminders, so on. And so there's a communication protocol that's followed, which is why we get these really nice response rates, considering this is all comers. This is not the willing, this is not the eager, this is everyone. So for example, in the last round of webinars, nearly 98% have attended so far, and if I know any, the rest will also be attending shortly. And the 99% reporting on their fidelity data for last round. How do we look at impact? So not just participation, but impact on the project. And one is our goal was really that these clinics would be comfortable and capable of delivering these best practices. So we monitor fidelity to the 5 best practices. Clinics self-rate every 6 months and submit their data. There's only 5 items, and there's 1 for each best practice, and it's an anchored 5-point Likert scale. We also look at the outcomes in Medicaid. So this is assessed quarterly as the proportion of clinic clients that have an OUD diagnosis and have had a mental health clinic service during the past quarter. We look at 3 different measures. So to get at screening and identification, we look at whether the individual had OUD in any setting. Say they presented with an overdose in an emergency room, or they were getting services in some other setting. Is the clinic aware? So if they've screened and identified this individual, are they documenting that? Do we see an OUD as a diagnosis? Doesn't have to be their first. They could have depression and OUD. Is it documented anywhere? So that's one thing we monitor. The second is there a naloxone prescription? And any naloxone prescription in the past year. And for MAT for OUD, we're looking for any MAT in the past year. Again, for these clinic clients with OUD that have been served in that quarter. We also look at graduation. So clinics that report high fidelity implementation of all 5 best practices are in a sense nominating themselves for graduation. They said, we've done it, we've got it. We then do a qualitative assessment of fidelity. So 2 trained readers interview to determine if they would confirm those fidelity ratings and that the clinic is indeed meeting the graduation criteria. If they do meet full fidelity, they graduated, but if not, they get some feedback and technical assistance because they're often quite close. It's not that they're making it up, they're just trying to get out of this. It's not that at all. Like, my sense is really that people did feel in good faith that they had really done it. And if there's a couple things that they needed to work on, that's something that we help them with. So this is what that fidelity data looks like. Here we're reporting the numbers of clinics reporting full implementation by type of best practice here, both at baseline and on the 1st, 2nd, and 3rd follow-up, which brings us out to this past spring. The data from the fall is still being analyzed. So we have significant improvement in the mean fidelity score for all 5 best practices between baseline and the most recent follow-up that we are presenting here. But there's a couple things that'll pop out at you, right? That referring and screening seem to be the easiest for the clinics. And that MAT, the place we really want to end up, is really lagging far behind. So we started this project and it would be over, remember there's 482 clinics or so. We started a little bit over 10% and we haven't hit 20% of the clinics yet who are reporting that they can do that. How do the Medicaid measures look? So these are obviously independent of what the clinic is reporting. So the 3 Medicaid measures we talked about, starting with the top one, is increasing clinic clients with OUD who have received any MAT in the past year. And the first time we saw these numbers, we thought they were too good. We thought, in fact, they were so too good that we didn't present them the first time we ran them, because this can't be right. But you know, okay, it looks after looking at a number of different ways, it does appear to be right. I mean, it's pretty low bar. You had any MAT whatsoever in the year, a pretty low bar, granted. Still, we thought maybe it was high, but it improved. Right? So it went up about 10% over the course of this initiative. Increasing the identification of clients with OUD by the mental health clinic. So again, this is that case of the person who presented to an emergency room, was given a diagnosis of OUD, is getting treatment in the clinic, and the clinic doesn't mention it at all. And we're trying to increase that awareness, and at the height, you know, it was almost at 50% there or so, did drop back down a little bit. And you can see this line here for COVID is that for some of the measures, there was a flattening or even, you know, dips that occurred in this kind of COVID world that we're in. And people are probably aware, but over 90% of the services delivered by clinics shifted to remote during this period. Now, we've seen that people are starting to go back over the summer, for example, but you know, I don't know, say, with this latest wave, whether those trends, people are going back to remote again, which could present some challenges for identifying OUD, for feeling comfortable starting that, for you know, treatment in general. Just a quick look. These are not, we weren't pushing any particular form of MAT, but you can see that as MAT has increased, that is largely due to increases in buprenorphine. Graduations. So our class of 2021, 33 clinics self-nominated by reporting full implementation and high fidelity for all 5 best practices. 12 clinics achieved graduation through the you know, kind of qualitative interview to confirm, while 11 others are receiving additional technical assistance but are close. And of note, one of the questions we have was like, you know, who is succeeding and why are they succeeding? So of note, the CCBHC programs, there's only 17 of them in our state, but 29% graduated in that first class, compared to less than 2% of the non-CCBHC programs. So kind of they're better funded, and there's an expectation that those programs do deliver substance use and opioid use disorder. So you know, on the one hand, it's not surprising, but it is kind of maybe noteworthy. But exciting news in the class of 2022, an additional 46 have raised their hands and said that they are fully implemented, and those interviews will come underway. So in conclusion, the mental health clinics have made significant improvement in the implementation of all of these 5 best practices, with the greatest improvement in screening for OUD and the smallest improvement for delivery of MAT, and significant improvement for all the Medicaid measures that were monitored, and 12 clinics graduated to date, another 15 close. So what were some of the challenges and questions for the group? And I'm going to raise this now, and then you know, we can decide if we'll talk about it at the end. But some of the things that we'd love to hear from you about, you know, and just to talk about challenges and questions. So the COVID-19 epidemic, you know, unfortunately, there was actually a hope early on that maybe it would diminish opioid use disorder. Who knows? It was worth hoping, and that, unfortunately, as you know, is not the case, and in fact exacerbated it. And you know, some of the challenges of initiating that mood via telephone or via telehealth. Graduation. So we have clinics beginning to graduate, which is incredibly exciting. How many do we need? What are the thoughts about best methods and considerations for a needs assessment? We haven't told anyone they are off the hook, but do we really need them all to do? You know, so that's one of the questions, right? What do we need? What's a good way to think about needs assessment? Trying to understand better who's succeeding here, right? So we shared that one data point on that special CCBHC program type, but what are the characteristics of successful clinics? And we have some data sources for that, right? We have the qualitative interviews from the graduated clinics, and we also have quantitative data from the surveys they submit and from Medicaid data. And what additional interventions do we want to test or add to move more programs to deliver MAT? That's where we're really lagging behind and so important. There's a new initiative we're launched. This is a voluntary quality improvement collaborative, and 140 mental health clinics have enrolled. There's a fiscal incentive provided for the non-hospital affiliated clinics for participation, and they're required to do project planning and get individual clinic consultations and monthly. It's a more aggressive. It's not every 6 months something happens. This is sort of monthly data reporting, monthly planning, monthly group meetings, a little bit more accelerated. But I'd be really interested to hear what this group thought about, you know, is there something we can learn here? It's such a, you know, with quite a few clinics that we're working with and trying to move, you know, is there something that would be worth testing here? You know, something that we could maybe try out or randomize different clinics to get to see what we can learn about what's really helpful. So that is it. Yeah, a little appendix.
Ollie, thank you for that wonderful talk about this very exciting and extensive initiative. And now I'm introducing Dr. Tim Hunt, research scientist at the School of Social Work and one of the key investigators. He's going to in the Healing Community Study in New York State. And Tim is going to talk about experience engaging mental health programs as part of this effort to intervene in communities. Tim, thank you for joining us, and you have the floor.
Thank you. Wow, what great presentations to kind of lay the groundwork now to move toward being able to describe this very multi-layered study here in New York State, but also the opportunities. As Dr. Finnerty, what a case you're making for quality improvement, for integration of care. And Ms. Chen, the data pointing toward the risk factors, the co-occurring disorders that we really should be addressing. It's very inspiring and also daunting at the same time. So you mentioned you wanted to hear a little bit from the community, and hopefully I'll do that today in this presentation. This is a very large study. Again, just some acknowledgments here, and our site PI, our contact PI is here on the call as well, Dr. El Basel. And we appreciate the support of NIDA and SAMHSA in this venture to reduce overdose deaths in New York State and in our partner states. Thank you so much again to our colleagues here at Chosen, the Chosen Center that was actually launched to address this issue, particularly around the opioid crisis, but also the ongoing crisis of substance use in our country and the factors that are leading to risk and greater risk. My colleagues at SIG joined also in this process and are hosting and the home host at Columbia University for the Healing Community Study that we'll be talking most about today. So briefly, I just wanted to give introduction to the core elements and the framework of this Healing Community Study and the intervention that is being now tested, to give 3 examples from communities or counties that have engaged the behavioral health system, and also really generate some ideas about how we can move forward to do a greater job of integrated care and collaborative care. You've already laid the groundwork why this is an issue, both nationally and in New York State. Particularly, our work has not at all stopped. It actually has been exacerbated during COVID 2020 as we saw overdose death rates increased by 28.5% here. We still have a lot before us to understand, and we know that currently there are a lot of studies that are looking at COVID, its impact on increasing risk, and certainly mental health, isolation, anxiety, depression, and even domestic violence we're seeing are contributing factors that we need to continue to understand and how to intervene. We also need to see as the epidemic or the crisis is changing, where synthetic opioids have taken over as the greatest risk factor for fatal overdose. The co-occurrence of fentanyl within other substances, stimulants like cocaine, is we have to continue to look at and do outreach and treatment for those who are using polysubstances. And it's not only opioid use disorder. Again, we have other polysubstance use disorder, and we need harm reduction strategies to engage people in a person-centered way, wherever they are in their readiness for improving quality of life when it comes to substance use. You see the escalation of overdose, the pre and post-COVID. I was just mentioning, and so we have a lot of work here to understand at this time what COVID did and increasing that risk, but also what kind of opportunities are there as well. We need to look at also at disparities. Not everyone has access to treatment in the same way. The Healing Community Study is very much committed to looking at engaging BIPOC communities, underserved communities, and communities of color who we're seeing at increased risk for overdose nationally as well as in New York State specifically. You see a 30.8% increase in 2020 of overdose deaths, the greatest increase in 3 years. We're very concerned about our Black non-Hispanic populations and the extreme increase here. And of course, the role of fentanyl in the overdose crisis that we're facing today, from a supply issue as well as from a treatment and response issue. At the same time, this crisis has created some changes in regulations that have also created opportunities. Dr. Fenady mentioned telemedicine and how the field rapidly scaled up that method. At the same time, there are some benefits from that for engagement and retention that we're seeing. So that includes for medication for opioid use disorder as well. So these loosening regulations give us an opportunity to be more creative, to be innovative in the way we engage people where they are in the continuum of seeking help. This particular study and coalition-specific intervention is also engaging stakeholders across sectors. Certainly behavioral health is central to this engagement. It certainly does take a community to combine efforts to address crises like COVID and overdose at the same time. And this intervention does it. So this particular study, the Healing Community Study, as I said, funded by NIDA and SAMHSA, is a multi-site study evaluating an intervention, community-led intervention, data-informed intervention in a randomized controlled trial in communities with a wait list design. You can see here we have many different investigators engaged in this study with our goal is to reduce overdose deaths over the 3-year period. Our original goal was at least by 40%. We are a company in Kentucky, Massachusetts, and Ohio, in New York as well. And this, you can see in New York, we have around 100 investigators that are working with us on this study. And it's been quite actually rewarding to work with many on this call, actually, as we've contributed in many different ways, but to learn from each other how to best engage communities effectively. The PRISM REAIM was adapted model to guide the intervention design and study measurement. This particular framework is meant as an implementation framework, looking at both internal and external context factors that impact the reach, effectiveness, adoption, and implementation, as well as maintenance of the intervention itself. And of course, we're looking at reach and penetration into the populations that we're trying to reach who are at most risk for overdose. These are our 16 counties here in New York State. The counties were chosen because of the rate of overdose. It must have been at least 25 per 100,000. Also 30% rural were selected and randomized here. As you see, our wave one will be our implementing now the intervention through June of this year. We are now in the comparison period. We will be launching our wave two. We're now in phase 0 with wave 2 and launch the active intervention in July. We have a lot of opportunities here to partner with OMH, OASAS, as well as DOH, our critical partners in this study. I want to thank specifically, Annie has been so supportive in engaging our community partners, as well as Dr. Sullivan, who is Commissioner Sullivan, is our representative to the national consortium. So she's been very active in our state CAB. We really appreciate her support and working with Dr. El Basel. Here we are with this timeline. As you see, I just pointed out that we're right here in the comparison period. We will be launching wave 2 in July, and we'll have an 18-month intervention period, and we will begin sustainment period with wave 1. The intervention, very briefly, has 3 primary pillars. It is promoting evidence-based practice in what we call the ORCA, or the Opioid Overdose Reduction Continuum of Care. This is a selection mainly focused on overdose education and Narcan, medication for opioid use disorder, as well as safer prescribing. Community engagement is a core component of this, which is built on building coalitions in our 16 counties here in New York, some of them new, some of them remodeled to work with the Healing Community Study, and also a communication campaign, 5 different campaigns that have been launched. The engagement, again, as I said, focused primarily on coalitions. These are designed and led by communities. We partner with local commissioners of health, sometimes of public health, sometimes of social services in each county, and helped develop and tailor a coalition, sometimes between some 12 to up to 40 members in these coalitions, with stakeholders across different sectors, including people with lived experience, families, and I'll talk a little bit about the primary sectors that we must include as a requirement to be in the study. We also build champions. We engage champions when it comes to evidence-based practice. Those champions can be located and familiar with medications for opioid use disorder, but also other sectors, champions like data-driven approach as well. The key stakeholders, as I mentioned, are the coalitions. We are collecting data from them, both qualitative and survey, and observing coalitions. We are selecting champions. They are selecting champions to lead work groups. We have our state CAB. We also have funding that we're sharing to promote evidence-based practice, as well as our local and state leadership that are always helping us with getting data. For example, data for the first time where Medicaid and other service level data is combined with other levels of risk. For the first time, being able to report that back to communities. The equity statement I mentioned earlier, always using a frame to make sure people were included at the table. And we've also, I'll say a little bit about in my examples in a moment, we've done cultural competence trainings in our mental health clinics that have been engaged. We've also done training with opioid use disorder around reducing stigma, even among providers. Our model, as I said earlier, really was centered around the local stakeholders, grounded in their decision-making. We then gave monies to hire local staff to lead as a program manager and to engage the community. We provide technical assistance, investigative support, is what we call external support. And more specifically, we're providing technical assistance and training that really is built on federal and state resources, and also consultants that we have as part of the study as well. As you mentioned earlier, the Opioid Response Network, the Department of Health, and OSS have been very central to this component. The intervention is a phased approach built on the communities that care model, adapted for the opioid crisis. This particular phased approach begins with structuring a landscape analysis, developing a baseline in each community, developing community profiles, structuring the coalition itself with its own mission and charter, work groups. It's introducing data through a data dashboard. It's then moving toward action planning and eventually implementation planning, which is also then followed by quality assurance and implementation examination to see which is being implemented effectively and what course of change or course correction is needed. The actual outcome, the main people that we're trying to reach here are listed in our ORCA menu, what we call, and you see here one of those risk populations is comorbid medical and mental health issues. So outreach specifically to these particular populations are built into the strategies that are selected by communities. I mentioned earlier the data-driven approach. We capture data from both the state and local level, working with our local data coordinators, which are so brilliant, many of them epidemiologists, to capture that data and display it, visualize it on a local portal and dashboard. These are examples also of the community campaign, which are a lot about destigmatizing opioid use disorder, informing around Narcan, and around the importance of staying in treatment, getting into treatment and staying in treatment, right, to improve outcomes. These are the three sectors that must be chosen in action planning. The communities must choose an intervention or strategy for healthcare, and these are the sectors of the healthcare that are suggested. Criminal justice is a very important sector to be intervening, especially in our jails and prison discharge, working with probation, parole, and we've actually helped the state develop opioid courts in several of our communities as well. We know that people engaged in the justice system, many of them have co-occurring disorders that need to be addressed, and there needs to be much improvement, but certainly offering opioid use disorder treatment, substance use treatment is really critical in these settings. And finally, the behavioral health system, which we're talking about here today specifically. So these are the three practices I mentioned earlier, the EBPs, as we call them, that must be chosen and implemented as part of the trial and part of the intervention. So promoting Narcan distribution and education, working with the state OOPS programs has been very critical in New York State. We're very lucky to have them as a resource and to have access to Narcan. Medications in all its forms to expand access to build linkage and retention efforts. And then finally, increasing safer prescribing through educating providers, as well as increasing take-back programs for medications and working with pharmacies and other clinical providers. Across the continuum of care, again, these both active prevention and secondary prevention have been chosen as part of the evidence-based practices here. We did also some modeling. I'm not going to talk very much about some agent-based modeling, but I wanted to point to this specifically today to say it is data-driven, and communities were informed about this modeling to see how much they had to increase of Narcan or how much they had to increase medications in the community to get to our target, reducing overdose by 40%. And this modeling built on data from 2020 and ultimately led to the conclusion that increasing retention in care impacted the amount you had to increase both Narcan and buprenorphine initiations, right? It looks a little like this. So how many times do you need to increase the access to buprenorphine or naltrexone, or how much Narcan do you need to increase? This was if you have a retention rate at baseline versus we also tested if we increase retention by 25 or up to 50%, right? So if we increase retention in care, which we're all working toward, then we can also then maybe reduce the amount we had to expand these other EBPs. So this is the data-driven approach that's part of this intervention. Of all of our 8 counties, they've chosen 172 strategies, right, across these 3 EBPs. Today, we're going to focus on menu 2, or the MOUD strategy, if I can use that acronym. You can see here some of the success so far in the linkage to MOUD in across our counties. You know, up to 305 people linked to an MOUD program in one county. We provide technical assistance, as I mentioned earlier, building on both federal and state resources, as well as our internal resources. Let me give 3 examples then, and some of the successes and challenges that came along with these 3 examples, working with behavioral health and mental health clinics in 3 particular counties. We really want to thank our data coordinators in these counties and our program managers who helped develop this particular presentation today. So the first is a SMART goal or SMART strategy, which is to expand MOUD inductions by bringing in a waivered contracted prescriber, a consultant, to do inductions and to work directly with the mental health clinic. Given that we had an urgent need, while this particular clinic may be expanding its license category, they decided to move forward with a consultant in this case who both worked across the system with a licensed OASIS program, as well as the mental health program, and also a homeless shelter. So it really is about coordinated care. The key components here are this mental health coordination and linkage between the provider and the mental health clinic, the hiring of a part-time NP also who worked in this mental health clinic to expand hours, and also to do 1 day a week in the licensed OASIS program. So this expansion strategy reported 91 inductions in 2020, from 2020 to 2021, 13 in December and 7 in November. The retention rates are also particularly interesting here. For the first month, 72% retention rate for those who were inducted on MOUD. There was, of course, a drop-off at 6 months down to 32%, but this really is still better than the general national average around retention. This network of coordinated care is a model we really are building on in all of our communities. The centralized partner of this Department of Mental Health, working with its partners of OS license programs, as well as other social services. Key here is also peer navigation and outreach to help link them between partners. So that means literally the consultant provider calling a peer, having them link them to go to the pharmacy, as well as then to link them to aftercare, which often include case management and other services. Successes are the leadership from the top. The Director of Community Services and Social Services is a champion in this area. The integration of patients quickly in the first year, the retention rate, the peer linkage and partnering with a peer-led organization in this community, the training of staff in this mental health clinic to reduce stigma toward opioid use disorder, as well as having a peer co-located in that actual clinic who helps with navigation. Some very much challenges here are the same day initiations because of the full schedules of our providers. You'll see me talking about workforce shortages and staffing shortages, which really is a challenge throughout. Making sure caseloads are manageable. And then the follow-up of engagement with a peer. When you're working with a peer-led organization, often there are challenges there that come along with the stability sometimes of that organization, and the need for supervision of those peers is really critical. This is an example in which a person who was undomiciled, living in a homeless shelter, saw a flyer, a communication flyer. He was then asking about, where do I get help for my opioid problem? He was then linked to the consultant, who then was linked to the peer and then linked to aftercare at the mental health clinic. So this was a success story. The second example is a very exciting example with also opportunities. The leadership from the top, this county executive in this particular community, was very much a champion to get this urgent care mental health co-located center opened in only 2 months. It was a rapid opening of the center, an expansion of an urgent care center from one county to another county. So this is currently, this particular county has been able to deliver 2,000 kits along in the county. They've put up naloxone boxes. It's part of a smart strategy, and they're using vouchers to engage people into care and also in retention. So I put that on here just to show you it's not only one strategy, but multiple strategies working together. This particular urgent care access was needed, 24/7 access using virtual crisis team. So the goal in this was to at least engage at least 50 individuals with co-occurring disorders, mental health and substance use disorder. It also hired a family peer to do family engagement at the same time. So this is hours for psychiatrists, it's hours for social work, it's hours for peer services. Their design is really much, they call it a front door to behavioral health integrated services, right? They want to make it as friendly as possible, as home-like as possible. Walk-in services are available. It's immediate as well as virtual. It's actually co-located across the street from a local hospital and emergency room, specifically in an urban area. So you see the staffing available here. Now, some of the challenges is how do you offer medication-assisted treatment in a traditional mental health way? Sometimes it causes challenges. So the triage approach works to reduce liabilities, making sure that people who are coming for care, who have prescriptions already, that there's coordinated care, right? But often people in the state of crisis, they don't have the documentation they need. They may not have phone numbers. They may not have prescriptions. So they show up in an urgent care setting. And so they immediately are seen by a social worker, then a nurse, to begin to collect data. The triage approach. Can we get in touch with your current provider so that we can offer you a bridge script? Now that happens sometimes, but unfortunately in this setting, it's not happening enough. So day one.
Tim, I'm sorry to interrupt for a second. If you could wrap up quickly, just want to leave a little time for discussion.
Absolutely. So I will walk quickly through this. You'll see they have a day 1, day 2, and day 3 strategy with someone with opioid use disorder. This is not sufficient. Someone who's in crisis, who's in withdrawal, and who needs immediate assistance. And this particular clinic is looking to improve the way it's rolling out this particular strategy. As you see here, there have been some challenges around utilization, greater advertising. The traditional assessment is not working for urgent care. Better connection with local SUD providers. Expedited lab work is needed. And then staff shortages, as I mentioned earlier. The final strategy is in a clinic, very similar, but a partnership between family planning and this licensed mental health clinic. The hiring of a nurse practitioner, as well as a social worker and peers to work in this cross-sector setting. You see here the promotion of medication, the receiving of medication in this mental health clinic has been increased, and I hope they're one of those that you were talked about, Molly, earlier, the programs that talked about their full fidelity implementation. So this began, though, was not so easy in the beginning. The leadership in this county was critical as well, but a champion in family planning was the key in this area, a nurse practitioner who also serves as a mentor to psychiatrists and other providers in the mental health clinic. The social worker is seeing 98 patients. She's seeing them both in family planning as well as in the mental health clinic. The leadership attitude in this particular clinic has evolved, and was wavered during the last year for the first time. The challenge has been they have lost one of their key providers recently, and now they're hiring again. So there's been a major setback in the provision of MOUD because of staffing. And the take-home point here, in rural and or small communities, the access to providers is very challenging, right? So often they will take whoever they can find. And that means that provider's clinical ideology or attitude can impact the entire quality of care in a clinic. And so that's something we want to continue to think about. In your spare time, at some point, I would like you to share with you this video of Laura Churchill, who's an amazing champion. It's a 2-minute video. You can watch it at your leisure. Finally, in summary, we need urgent integrated care that is, first of all, creative to begin with, and then sustainable. Sometimes we have to do workarounds quickly to get programs up and running. A person-centered approach is key, meeting people where they are with harm reduction integrated. We need more active prescribers, not just wavered prescribers, and that we also need methadone in rural areas is really a critical area to expand expand access as well as linkage. Stigma is still a problem among providers, and we need better coordination cross-sectorial, especially with criminal justice, and the building in of sustainable approaches with peer navigation is key. Supervision and staff pay is really key. Funding for peers is really critical. So thank you, and look forward to some discussion about opportunities together.
Yeah, Tim, thank you so much. I mean, it's a huge project, and you've been really hands-on in all these communities. So thanks for sharing, especially your reflections on some of the specific initiatives. So I would ask the audience to put their questions in the chat. In the meantime, Molly raised a question we could start discussing perhaps among the panelists of where do we go next? And I wonder, Molly, what reflections you have hearing from Tim and vice versa. Tim, what reflections you have hearing about the mental health initiative in terms of where we go next with trying to increase treatment, particularly for opiate use disorder?
I love Ken's idea of seeing how these projects intersect, right, and understanding, we're saying what has helped some clinics succeed and others not, and understanding, which are the clinics that that the HEAL project has really been engaging with, and seeing whether we can, whether that's a contributing factor, right? Being activated in a way by the HEAL project, and whether that kind of helps to move people along, I think could be really interesting.
We're learning early on. It's just we're still in the lessons learned period about what factors did lead to success. But what I've pointed to some is leadership and champions are really key. I would like to also respond to your questions. How many clinics does it take? The problem in rural areas is that one clinic sometimes is in the whole county, or maybe they don't even have a clinic and they go across the river to that clinic. So sometimes I'd say it depends on the location, right? So making sure we're working with those clinics that exist, especially in rural areas, but also looking at other mobile or telepractice efforts that might augment our work.
So it sounds like yeah, go ahead.
Oh, I was just going to say some of the modeling, trying to understand needs assessments and the best way to, again, as we said, we're asking all the clinics to step up, but, trying to get a better handle on what the needs are. And I was really interested in the modeling data that you were showing, and what it was that you were modeling, and you were sort of looking at targets for starting services and things like that. But But if you backed it up one to say, well, then what does that mean about how many clinics and what regions you need to be able to deliver those kinds of services? I think there could be something really helpful to look at there.
We have a question from Yunyu Xiao. I'm sorry, I'm probably not pronouncing that right. Given the increase in suicide attempts, which I was struck by that data also, how do we target suicide attempts among OUD patients? What are the challenges and opportunities? Have the linkage been applied to suicide prevention? And a related question, are there particular difficulties among racial and ethnic minority groups? But let's start with the first one. What can we do about this co-occurrence between suicide and opioid use disorder?
We actually have an intervention called Zero Suicides that was adapted to zero overdose, because, and the core practice is the same, to identify risk, but then also make a plan. So we should be integrating that, and OASIS has also decided to make sure all their license programs will integrate this particular platform, because it's so critical. Sadly, listening to our medical examiners and coroners also do a risk assessment of fatalities. They're looking at it. Sometimes they don't know if it's a suicide or was it an accidental overdose, because this person did have some history, with other suicide attempts, or maybe taking multiple medications. So it certainly is a population that we need to be looking at doing greater outreach with, and doing safety planning with.
Yeah, Rick Rees actually at the University of Washington has developed a very nice intervention for suicide risk among people with substance use disorders that has to do with educating both the clinicians and the patients about suicide and how to look for the risk factors in their patients and also in their peers. And it might be worth looking into it. It's relatively straightforward to implement, and it's peer driven. So Jeremy Kidd is with us, and Jeremy has a little bit of experience implementing some interventions in one of the mental health clinics here in the Washington Heights community. So Jeremy, I think you were going to tell us a little bit about your work. You are muted. There we go.
Ned. Yeah, and thanks to Derek Levins for inviting me to come on today as well. And I was excited to hear Molly Finnerty speak about the initiative, because I've been on the other side as being one of the sort of like local practitioners in the Washington Heights Community Service trying to do this quality improvement. And I started in August of 2020 at the Washington Heights Community Service, which is a set of 3 clinics here in Upper Manhattan. We serve mostly folks with severe mental illness, schizophrenia, and bipolar disorder. And one of the things that's become kind of clear is that getting providers to take on something new, to learn something new, is only successful when they see it as something that's going to be relevant to the work that they're doing and relevant to the patients that they do care deeply about. And so I think that's been the challenge that we've seen. And one of the ways that screening has actually been really helpful is implementing universal opioid specific screening, as is in that first best practice through the OMH initiative, has helped providers begin to notice the opioid use among their own patients who they already have relationships with. And then the challenge is sort of convincing them that they actually have the skills, and maybe you're the only ones who have the skills to treat OUD in this very particular population, because they're used to working with folks who have active psychosis and who have difficulty managing medications. And so for instance, one of the things, we were trying to get people to prescribe naloxone, and that just never, ever worked for our patients, because you provide the education in the office, they maybe pick it up or they don't, and then they didn't really retain what you told them. And a lot of people don't have smartphones. And so we're in the process of trying to become an overdose prevention program now to be able to offer that in a more systematic way on site. But it has been a real challenge. But I think we're beginning to convince providers that for many of our patients with severe mental illness, there's no great place within this current fragmented system for them to get care. And the best place actually is within their mental health clinic in an integrated sort of specialty way. And I would be curious, Molly, if you've heard from other programs about what's been helpful in that sort of culture change and convincing general psychiatrists to sort of see this as part of their best care that they're offering their patients with severe mental illness.
Yeah, that's a great story. And, you know, we should write that down and include that in our, amongst the stories we try to collect. And so I mean, one of the things, you know, you're hitting it exactly. And I think Tim said something similar, that it's a really big challenge in mental health clinics to convince psychiatrists that this is their job. They just feel like, isn't that for someone with a substance use fellowship, or isn't that for somebody who's not me? You know, that's not what I'm here for, you know? And I think it's interesting in Washington Heights, I thought you were gonna say something different, is that at least at a statewide level, there is a lower, for people with schizophrenia, there is a lower proportion that have that opioid use disorder, but interestingly, that are among the highest risk for overdose if they do happen to have it. That it's kind of interesting the way that works, is that the settings that are more serving that sicker population have lower prevalence but higher overdoses. And so really important that they do get comfortable. I like your argument that you're saying, you know, who else would feel comfortable treating someone with serious mental illness, and you know, and these kinds of conditions, with or without opioid use disorder, except for people who have chosen to specialize that in their careers, so that they're really the perfect people. I think Annie might still be on, and she is someone who is constantly talking to our clinics and grappling with this very question, and also like stigma, you know, even people, they're comfortable working with people with schizophrenia, but oh, not those opioid user folks, you know, so that there's a stigma issues, there's all kinds of things that have come up. But Annie, it'd be great if you would jump in.
Sure. I mean, well, you know, we appreciate Jeremy on the call since we talked to Jeremy last year and are trying to get him to do some training with us for this initiative. So, you know, I think it's so funny. Earlier today, we were on a call with about 40 clinics talking about this exact question, and getting them to share, you know, they had conversations with their prescribers. What did their MDs and NPs say in terms of where the concerns are? I think there is a lot of education that needs to happen around some kind of OUD 101 basics that they didn't get, because that has changed. You know, times have changed so much since they were in residency and since they were in their early practice years. A lot of concerns about diversion and liability, where, you know, hearing from a social worker like me isn't going to be as useful. And so what we're really thinking about is, if they don't have a champion like a Jeremy in their agency, in their clinic, and they don't have, you know, a friend that they know who's got this expertise, where can they hear it from other, you know, from professional colleagues? Where can they be in a small group with another MD, another psychiatric nurse practitioner, to have these conversations and to see that, you know, actually, is diversion really an issue more than the other psychotropic medications you're prescribing? Is the liability really so much more? Understanding the population a little bit better. These are people that you're serving. They're not a new population that's coming to your clinic. These are your clients already. So I think, you know, when we checked with people today, even, you know, it was a lot of just, I think, lack of experience, lack of knowledge, lack of confidence, you know, a lot of concerns about home induction, or they won't have time to do induction, a lot of those kinds of things. So I think we're really thinking about how can we pair in small groups MDs and NPs with kind of champions outside their clinics if they don't have that champion leadership within the clinic or agency they're in. Because when we talk to people who have been successful, when we talk to them, those who have graduated, what they say is, yeah, we got a new medical director, and they told us we had to do this. So it was a huge change, but we're here, now it's easy. They had that person in-house.
Yeah.
Right. I was just going to add that, that all of that, absolutely, Annie, everything she just said. And I think that, I didn't hear it get mentioned. If it did, I apologize for repeating it. But there's the National SAMHSA PCSS, which is the Provider Clinical Support System. And any individual can get linked with their own mentor for simply just asking a question or hand-holding through a patient. There's also support groups, like there are clinical practice groups that meet as part of PCSS. And it's all free. And a lot of our faculty are part of those, some of those mentors, and Nasser Naqvi actually takes the lead for New York. So, that's available. Now, I totally agree there has to be a champion is the best, but if you can also, there's plenty of help in terms of supervision if people want it and want to reach out for that and feel comfortable. And particularly with fentanyl on board now, people are even more scared about doing inductions and getting help with that. So, there's the resources are there. So I just recommend that people, as a disclaimer, I'm the medical director of it, but I still think it's a good thing. So, people can avail themselves. It's PCSS Now. If you could just Google it, people can get on and look at it.
Okay, folks. Well, we are at the end of our time, and that concludes our session. I want to thank all the speakers, and I want to thank Jeremy and Annie for jumping in. And I'm just going to echo Jeremy. I love your quote. Who else could treat these patients? Who else has the skills to work with these difficult patients than mental health clinicians and psychiatrists? I love that. Who else? So thank you, everyone, for your participation and your attention. And I think you have the contact information of the speakers. So let's keep the conversation going. And it looks like the video's in the chat from Tim. Thanks, everybody, and have a good evening. Take care.
Thank you.
Thank you.